Hello, everyone. I'll give folks another about 10 seconds to join the line as many are, and then we'll go ahead and get started. All right, so as folks are joining the line, I just want to start off asking everyone to go ahead and mute yourselves. There will be an opportunity to speak towards or a little bit later in the hour, but please do make sure that you're placed on mute. So with that, welcome everyone to our joint prevention and surveillance September session of the Virtual Learning Collaborative, which is a partnership between NASTAD and CDC's Division of Viral Hepatitis. My name is Boatman Terry Reed. If I haven't had the pleasure of meeting you yet, I am the director of NASTAD's hepatitis team, and I have the pleasure of introducing you to today's session. Today's session is going to focus on elimination plans and specifically the development of those plans, the collaboratives that you're working with in order to develop them, but also the design of indicators and how you're tracking them. So for today's session, we'll start with an opening discussion of newly released CDC hepatitis elimination guidance presented by Dr. Nathan Furukawa of CDC's Division of Viral Hepatitis. Nate will be followed by a didactic presentation, from Colleen Flanigan, who's director of the Bureau of Hepatitis Health Care at the New York State Department of Health, and she'll be discussing New York State's elimination efforts and metrics development. Finally, Zakiya Grubbs, Viral Hepatitis Program Coordinator at the South Carolina Dept of Health and Environmental Control, will close out our presentations by discussing the development of South Carolina's elimination goals and indicators and lead us into a discussion on challenges related to tracking performance. So the big ask of all of you is to pay close attention during each of these presentations and really start to round up your questions, challenges, issues that you're facing so that we actually have a chance to hear from you during the hour and you have a chance to address them with the SMEs who are on the line, as well as all of your colleagues who are also themselves SMEs. So please make sure to have those questions ready to go. So I'll now turn it over to today's presenter and moderator, Dr. Nathan Furukawa. Handing it off to you.
That's wonderful. Let me get my slides up. All right. So thanks for that great introduction. And so I'll kick off the session just by discussing just a review of the national and global indicators and targets that exist for viral hepatitis elimination planning. So of course, before we begin, the usual disclaimer that this may not necessarily reflect official policies of CDC and that I have nothing to disclose. So in general, when you're first exploring indicators and targets, it can be really easy to get lost and confused by the real large number of them and all the many types of indicators. So here I like to share just a helpful framework I use to help categorize them and think about them in my head. So first off, core indicators are those indicators that get at the population health effect of viral hepatitis. And those real numbers are number of deaths and new infections. Proxy indicators are measures that are related to these core indicators, but may be easier to measure than the core indicators themselves. And then for viral hepatitis, changes in prevalence can approximate rates of new infections, while changes in rates of viral suppression or clearance are closely related to hepatitis-related deaths. Programmatic indicators assess the impact of programs and their interventions on advancing elimination. And so for instance, the number of needles and syringes, someone's unmuted. Please mute yourself. So an example of a programmatic indicator might be the number of needles and syringes distributed per estimated number of PWID in the population. And that can assess whether or not there's a sufficient number of SSPs in your jurisdiction. So then finally, process measures can assess smaller steps that lead to a particular outcome. For example, such as trying to ensure that all labs are reporting 95% of hepatitis-related labs to the health department for surveillance purposes. So the core and proxy indicators can really show the public health impact of your elimination work, but it's the programmatic and process measures that can provide you more details on the effectiveness of each of these interventions and where things might not be going well. When thinking about the target, you can ask yourself whether or not they're relative or absolute targets. So relative targets are based on relative improvement over time compared to a specific baseline, whereas absolute targets represent an actual population health threshold and is not related to a baseline level. So whether you choose a relative or an absolute target can depend on the number of factors, including knowledge of baseline values and just the nature of your epidemic. So for the remainder of my presentation, I'll do just a quick introduction of the indicators and targets that exist at the global and national level, and then my colleagues will delve more into their jurisdictional experiences at the state level. So at the global level, WHO has come up with targets for core indicators of hepatitis B and C elimination, and that includes Hep B mother-to-child transmission elimination. And so note that WHO has both relative and absolute targets for elimination. So for instance, you can reach elimination by either reducing Hep C-related mortality by 65% compared to 2015 baseline, or reducing absolute deaths below 2 per 100,000. So in addition, the WHO targets are unique in that they include programmatic targets, which aren't included in our HHS National Strategic Plan. And so these programmatic targets get at trying to assess vaccination, testing, treatment, and prevention. For the HHS National Strategic Plan, there are 8 main indicators based on relative targets using a 2017 baseline. So each indicator includes an absolute value, a 5-year and a 10-year target, as well as the national data source that's used to measure them. And these key indicators include reducing acute Hep A, B, and C infections, increasing birth dose vaccination, increasing the proportion of people aware of their Hep B infection, increasing hepatitis C viral clearance, and then reducing both Hep B and C related deaths. So these key indicators can be really helpful as starting places when you're thinking about making your jurisdictional plan, and then considering whether to align with these national elimination targets. It's also worth mentioning that there are additional indicators addressing specific subpopulations that are disproportionately affected by viral hepatitis. And so this includes specific hepatitis B targets for people who inject drugs, Asian or Pacific Islander people, and then non-Hispanic Black people. There's also specific hepatitis C targets for people who inject drugs, American Indian, Alaska Native people, and non-Hispanic Black people. So depending on the population of your state and burden of viral hepatitis, you may be considering specifically identifying subpopulation targets that match the demographics of your state with the goal of being able to advance health equity in the process of viral hepatitis elimination. So some additional details about the types of measures and how to go about choosing them, you can consider reviewing the hepatitis C guidance on jurisdictional Hep C elimination strategic planning that was released earlier in the national meeting last summer that I gave a presentation on. And although this is Hep C in focus, the concepts about how to choose indicators and targets can be very translatable to hepatitis A and C as well. I think that's the summation of my time. I include the links to both the WHO and HHS plans that you can review at a later time. And I think I turn it over to my colleague, Colleen.
Thanks, Nate. And thanks to NASDAD for having me here today to talk a little bit about the hepatitis C elimination planning in New York State, as well as target and metrics development. Next slide, please.
Is there any video that you can see?
So the elimination planning in New York State was really all about community mobilization. All of the work was initially led by the community. Until the governor made the announcement for hepatitis C elimination. And that community mobilization began 2 years prior to the state's announcement and commitment to elimination. And so in the spring of 2016, there were meetings between the hepatitis C community leaders, the AIDS Institute, and our colleagues at the New York City Department of Health and Mental Hygiene. In the fall of 2016, those community individuals established a hepatitis C steering committee, work groups, and developed a set of recommendations around Hep C elimination. In February 2017, the community members held a full-day hepatitis C elimination summit where they presented the recommendations and released what they called the Hepatitis C Elimination Consensus Statement, and called upon the governor's office to make a commitment to hepatitis C elimination. Between February and throughout the summer of 2017, the community members traveled around the state in each of the region of the state and promoted that consensus statement and had organizations, well over 150 organizations that actually signed on to that consensus statement. And then the following March was when the governor actually made his commitment to elimination. Next slide, please. So when New York State announced its commitment to elimination in March 2018, that's really when things started to get moving in the state. So that happened in March. In April, in the executive budget in New York State, there was $5 million to start the elimination work. And then in July, the state announced its strategy for Hep C elimination in New York State. And that strategy included the establishment of the New York State Hepatitis C Elimination Task Force. And so very quickly over the summer, we pulled together everything that was needed for the first meeting of that task force. We identified the task force members, had those vetted through the governor's office, and established our process and timeline for the development of the plan. So in November of 2018 was the first meeting of the task force, and I'll talk a little bit about the task force in a few minutes. Through December 18th, or December 2018 and March 2019 was when the task force and the work groups began developing the recommendations. In April 2019, we took the recommendations from each of the work groups and ran it through prioritization. And then on June 4th, 2019, we held another full task force meeting where task force members provided any comments on the recommendations. And then after that meeting, we had a draft set of hepatitis C elimination recommendations. And at the end of June, we actually held several community calls to get input from individuals who are not involved in the process of developing those recommendations. And in January of 2020 was when our plan made its way over to the governor's office for approval. And at that time was when COVID was happening. And then, of course, some of you know, we've also had an administration change in New York State, and we are still awaiting the release of the plan. But that does not mean that we are sitting around and just waiting for the plan to release. We continue our work, and you can see down below our target development was done between October 2018 and April 2019. We started our metrics development in January 2019, and we continue that work, and I'll tell you a little bit about that. Next slide, please. So as I mentioned, our task force, so it was a 28 member task force. They were appointed, they were approved by the governor's office. And then we also had 5 work groups. And you can see on the right-hand side of the slide, each work group developed specific recommendations on Hep C prevention, testing and linkage to care, care and treatment, surveillance data and metrics, and social determinants of health. The task force and work groups were also charged with identifying key populations and settings that would be important for New York to focus on in its elimination efforts. And as I mentioned, the task force and the work groups developed and then prioritized the recommendations. Next slide, please. So as I mentioned, the executive budget in 2018 included $5 million. That money remains in the budget annually, and these are some of the activities that we are working on and funding as a result of those that funding. Hep C patient navigation programs, innovative models of care for people who inject drugs. We have expanded our successful HIV criminal justice initiative to include individuals who are infected and living with hepatitis C. We are building surveillance infrastructure, expanding hepatitis C testing, and also we did a very large New York Cures Hep C multimedia awareness campaign that was launched in 2019. And we are also doing some hepatitis C research projects. Next slide, please. So to start talking about the target and the metrics, the first step for us was really estimating the prevalence of hepatitis C in New York State. And this was a huge undertaking and involved our colleagues in our surveillance program at the New York State Department of Health, Lucilla Zamboni and her team, as well as our colleagues at the City Health Department, Angelica Bocour and her team. The city, as you may know, actually established a prevalence estimate in New York City. We also did some work in New York State some years ago on establishing a prevalence estimate. And then, of course, Dr. Eli Rosenberg and colleagues at CDC released a paper in JAMA in 2018 on estimating state-level hepatitis C prevalence estimates using some modeling. And so we built on that. We used synthesized New York State and New York City Hep C diagnosis data, generated state-specific weights by sex and race. And we feel as though this estimate better reflects Hep C epidemiology in New York State. And we also added New York State-specific testing and population sources for incarcerated population. So this took us a while to do this work. In New York State, we operate with two separate surveillance systems, one in New York City and one for rest of state. They're two entirely different surveillance systems. And so this took a lot of time for us to do this work, but we did come up with a prevalence estimate. Next slide, please. So from there, we worked on our target development. And so we pulled in members from the Hepatitis C Elimination Task Force, including those members of that Surveillance Data and Metrics Work Group. And we also contracted with the CDA Foundation, who some of you may know through other published papers. They use a disease progression model for Hep C epidemic using state-specific epidata. And then we also looked at PWID estimates, incident infections among PWID using modeling using mathematical modeling for Hep C transmission. And we came up with projected yearly and cumulative Hep C elimination metrics over a 10-year period from 2020 to 2030 based on the WHO goals, which everyone pretty much knows: screen, diagnosed, treated, new incident infections in PWID and liver-related deaths. Those were the cumulative Hep C elimination targets that CDA established for New York State. Next slide, please. So from there, taking the work from CDA, we wanted to look at, developing metrics and, how are we going to monitor our progress towards meeting those targets. And so we established a memorandum of understanding with the University of Albany School of Public Health to assist us with this work, metrics development coordination team at the School of Public Health, and also to use their technical expertise. We also established with UAlbany a hepatitis C elimination metrics advisory panel, which provided feedback on the implementation, on the development of the metrics, and the advisory committee is made up of individuals from New York State, but also national experts as well. We hold monthly work group meetings on the establishment of our metrics, and we do have a web-based dashboard that's under development that I'll show at the end of my presentation. Next slide, please. So the three primary metrics that we have come up with are Hep C diagnosis, hepatitis C treatment, and HCV incidence in PWID. Diagnosis, we will use our data source called HEED, Hepatitis Elimination and Epi Dataset, which I'll talk about. For treatment, we will use the same data set. And then for incidence, we are using a biobehavioral study conducted at syringe exchange programs across the state, and also using a hepatitis C recency assay, which has been validated by our lab. And we are able to collect that specimen through dried blood spot. Next slide, please. So just real quickly, I want to talk a little bit about HEAD, and I can take no credit for the establishment of HEAD. My colleagues Lucilla Zamboni and Larissa Wilberscheid are really the force behind the development of HEAD. It is a statewide data set currently under development. It will contain longitudinal information on patients with hepatitis C laboratory and case investigation information reported both to New York State and New York City through the electronic clinical laboratory reporting system known as eCLAIRS, as well as the case surveillance data system known as CEDIS and MAVEN for New York City. Data in HEAD will be updated annually, and the data will be augmented through regular data matches with vital records for deaths and births and Medicaid billing information and other communicable disease registry and case information, such as HIV case records and STIs as well. Some of the future uses for HEAD are to provide information for monitoring, as I've said, for our elimination metrics. So 2 out of our 3 primary metrics will be established using HEAD, development of clearance cascades to inform policy development and program planning, and the augmentation of surveillance data through data matches with other communicable disease registries. So the graphic on the right-hand side of this slide shows really very, very broadly how HEAD is being developed. Next slide, please. So I just want to end here with just a graphic of the landing page of our dashboard. We are working with the City University of New York to establish a dashboard, which is very similar to our ETE dashboard for HIV. If you go to hcv-dashboardny.org, you can sign up for updates. The site will go live when the plan is released, and this is where everyone can track hepatitis C elimination in New York State. So that's the end of my presentation, and thank you so much for your time.
Hello, my name is Zakiya Grubbs. I'm the Viral Hepatitis Program Coordinator at the South Carolina Department of Health and Environmental Control, and I'm getting my slides up. Thank you all for letting me speak today about our South Carolina Viral Hepatitis Elimination Strategic Plan and some of our indicators that we developed. So in South Carolina, we started on our elimination planning in early 2020, and we decided to use our viral hepatitis committee that had been formed several years prior as a mechanism for developing this plan. So over 2020, we met several times virtually as a large group, and we had about 60 or 70 stakeholders from a variety of agencies around the state, from healthcare to our substance use disorder treatment agencies, other state agencies as well. So with that group, we were able to meet and come up with a list of strategies and activities that everyone wanted to be included in the plan. And from that list, we broke off into 5 work groups based on each of these pillars: advocacy, policy, data, prevention and screening, and treatment, where the work groups use a large list from the larger group to refine it and make it into what we have so far as our plan. I will mention that our plan is in draft form and that the indicators I'm presenting today haven't been finalized. So you all are free to look through this and have a copy of it, but it's just not for wider dissemination at this point. So like I mentioned, our plan has 5 pillars: advocacy, policy, data, prevention and screening, and treatment. And each pillar incorporates goals for hepatitis A, B, and C. So for our first goal was reduce new viral hepatitis infections in South Carolina. Most of our goals reflect the goals from the HHS plan, but just adjusted for South Carolina. So for our first indicator, we want to decrease the number of newly reported cases of acute hepatitis A, B, and C in South Carolina by 25% by 2025. One key difference between the indicators that we have and from the national plan is that these are based on our actual case numbers and not based on estimates. And we'll talk a little bit about that in a second. And one of the things that we wanted to do with this plan is use a baseline closer to the current time, unlike the national plan, where the baseline is in 2017. So we decided at first to use 2019 as our baseline. We ran into a problem when we looked at our hepatitis A data. As you all can see, in 2019, we had 670 cases of hepatitis A due to our statewide hepatitis A outbreak. And that was very high compared to the 5-year average previously, which was about it was about 19 cases per year. So once we looked at that data and looked at this target, which is entirely too high, we decided that we need to move the baseline back 1 year to 2018 prior to the statewide outbreak, and also making sure that any progress we do make in hepatitis A reflects normal numbers and not an outbreak. Our second issue, and I imagine this is probably going to be an issue for a lot of folks, is acute hepatitis A. The number of cases that have been reported in South Carolina do not reflect the number of true cases due to underreporting and under investigation. And so we were kind of wondering, like, what should we do with that acute cases? We were wondering maybe if we should use chronic cases for our target, even though we wanted to measure new infections. And we also, through other parts of our plan, we wanted to increase number of screening. So using chronic cases wasn't perhaps the best measure for that. We also don't have at the moment any way to do any estimates of acute cases. And I know that other states and people may be using proxies such as investigations among PWIDs, cases among PWIDs and cases among younger individuals. So those are some things to consider. We haven't really come up with a solution for that yet, but I guess we'll have to figure it out. And we would definitely like to hear you all's thoughts on that. Our second indicator for goal number 1 is to increase the percentage of children receiving the complete Hep B vaccine series by 24 months in South Carolina to 85%. This differs from the national goal in that is looking for the complete series instead of birth dose data. We were able to use our immunizations registry data to get the 3-dose series data information, but we weren't able to pull the birth dose data. So that's one of the differences that we had to work with. Okay, our second goal is to increase screening for hepatitis B and C in South Carolina. Starting in 2020, we have been able to receive negative lab reports from labs that report to us electronically. So we'll be able to measure the number of individuals screened. We'll be able to measure screening. One of our concerns was whether we should measure the number of tests performed or the number of individuals tested. Some individuals may be tested more than once a year, and we just wanted to figure out which would be a better measure, especially since this isn't currently a national goal or indicator. We met with CDC and they suggested, for one, that we measure the number of individuals screened and that we also expand the hepatitis B screening past hepatitis B surface antigen to include other testing. And they also suggested that we change our baseline to 2021 due to, I guess, some of the limited healthcare visits that people had in 2020 due to COVID, and also changes to the acute Hep C definition. Okay, our third goal is to reduce viral hepatitis mortality in South Carolina. We're pretty much going to measure this the same as in the national indicator. Our fourth goal is to increase the number of people who have cleared hepatitis C infection in South Carolina, and we want to see an overall increase in Hep C infections in the state. And we're going to determine this using the guidance for the laboratory-based Hep C virus clearance cascade program guidance for state and local for local and state health departments released by CDC earlier this summer. Okay, some other concerns that we were thinking about when we were developing these indicators, disparities indicators, using our state epidemiology data. We have limited demographic and risk factor data to illustrate these disparities within the state. And so that's one of our concerns, knowing that there are disparities and making sure that we're able to measure them. Another thing we were thinking is how can we use other statewide data sources to demonstrate progress on these goals. One other thing I wanted to mention is that in addition to these indicators, we are asking our partners to provide us with information on some of the actions they're doing in support of the viral hepatitis plan. So we can use that information to support and to build on some of this information and give us some information on disparities through their programmatic efforts. And so hopefully that'll help us get a clearer and a wider picture of what's going on in South Carolina. Well, thank you all for letting me present today, and I'm very curious to hear what you all have to say. This is our contact information for the program. So thank you all for letting me present.
All right, thanks for that great presentation. So now we transition to the more discussion phase. And may I'll just start and kick off a question in that, we're, as a part of viral hepatitis elimination planning, we really want to acknowledge that there are disproportionate effects on different populations. And so I was just wondering if we could ask a broad question of how much did that health equity lens come into play when planning for some of these indicators or targets, and also just in general in your hepatitis elimination planning?
So Nate, in New York State, there are 4 overarching principles in our elimination plan. Their elimination plan and its recommendations are built on, and health equity is one of those overarching principles. We've also had some conversations as we started developing our metrics with the advisory group and internally about secondary metrics that would be more focused on ensuring health equity. Health equity is a very large initiative across the New York State Department of Health AIDS Institute. We have a lot of activities going on around health equity. So super important, and it will be included in the plan.
Like as I mentioned, I don't think we'll be able to measure health equity progress within our state, within our main indicators due to lack of data on disparities and demographics. But we are hoping to use the information from our partners, from the work that we're doing here at the health department, to illustrate some of the work we're doing in other marginalized and underserved communities to help support viral hepatitis elimination.
Zakiya, I noticed that in your presentation, you talked about in terms of trying to track new infections or a metric of it, you were kind of struggling whether or not to choose acute cases versus newly diagnosed chronic cases. And I have some thoughts, but was just curious, Colleen, if that was a discussion you guys had on your end as well.
So it was, if I recall, and I guess I would turn to Lucilla or Larissa, who's on the phone, to talk maybe a little bit more about that. My brain is a little bit foggy since this has been going on for a while. In terms of, we are looking at incident cases among the PWID population, because we do feel as though that is the population that we will likely see, new cases of Hep C. But I don't know if Lucilla or Larissa want to jump in there. Lucilla?
Yes, can you hear me?
Yeah, go for it. Lucilla is
Okay.
our hepatitis B and C surveillance program manager.
Hi, good afternoon. Yes, we consider that. It's just that there's some limitations to identify new infection versus recent infection. Many people, as you all know, carry the infection for years without experiencing any symptoms and knowing about it. I know there's been work in the lab to try to pilot some approaches, but unfortunately with the surveillance data, we can't. So at this point, we're not making a distinction between acute and chronic cases in terms of tracking the elimination metrics. But I think that is something that in the future we could explore as a secondary metric.
Yeah, and that's something, you know, of course, I totally agree with everything you've said. I think in general, like we're a little bit more just set up for reporting of acute hepatitis cases in a way that maybe the national infrastructure across the different jurisdictions is not quite set up for, like the, you know, registries, deduplication, and all that stuff that comes with making you being able to use new chronic cases. But you know, of course, whatever makes sense in your jurisdiction, and then if you have familiarity with it, you know, certainly you're more than welcome to choose new chronic cases over acute cases. I'll just say that it's you know, a point of disagreement in that even the WHO plan uses new chronic cases for their metric of decreased new infections, and then we use decreased acute cases. So one of us, you can be supported in either way.
Yeah.
But,
and then there are those people that say you should just throw out acute and chronic and just, you know, not even, not even make those distinction between the two. But of course, surveillance folks heads blow off when you talk about that. Yeah.
Yeah, excellent.
Another thing is also presenting these metrics to decision makers that aren't necessarily in public health. If we present that we only have 25 acute Hep C cases, that's going to, I guess, make decision makers think that it's not really an issue. And then trying to explain some of the concerns that we have based on getting that surveillance data, we probably will lose folks. And also, I was thinking we just want to make it easier because it's easier to say we're going to reduce all new infections. I mean, we're going to measure all new infections. And that seems easier to, I guess, for folks to understand. But then if we're saying for acute Hep C, we're going to measure this proxy and that proxy, it might get a little lost. So I guess that was another one of my concerns as well.
Yeah, absolutely. The undercounting of acute cases and just how that looks. Like, oh, only 25. That's not. I want to note in the chat, there's a note from Rachel, and feel free, Rachel, if you'd like to just unmute yourself and kind of share your comment.
Sure. Hi, everyone. So yeah, I mean, the one thing that comes to mind is that the very first or second surveillance report that we did for hepatitis C in 2013 or 15, I don't remember which one it was, but we first saw Hep C cases rising in young people in our prisons before we saw them in the state general population. Obviously, you know, it makes sense. People who use drugs are over incarcerated and over policed, but our prisons were also testing for Hep C. So it was like kind of a sentinel surveillance system, basically. And I remember at the time saying, we're not seeing this in the general population, but I bet you we will. And then in the next report after that, cases among 15 to 29-year-olds had increased 50%. And this is newly reported chronic cases. I completely agree with Zakiya that I think acute, I just don't even bother talking about our acute data because I feel like it could do more harm than good, honestly. But more recently, we've started looking at 15 to 39, because if you look at the data, like people in their 30s are also really starting to inject as well. But, you know, because there's such a bimodal distribution of cases, you know, like the young people and then the baby boomers, I feel like if you look at all newly reported cases and you don't stratify them by age, you're kind of missing the real trends. So that's kind of how we deal with it, basically. Yeah.
Yeah, we saw something similar, Rachel, when we looked at our prison data, our state corrections data, in terms of, the trends in the younger population. So it was very similar to what we were seeing in our surveillance data as well. And I know, for us, in terms of investigations, which actually happen at the local level in New York State, there is a sort of a prioritization that the local health departments go through in terms of determining which cases that they need to follow up on. In cases in individuals, in younger individuals, is definitely a priority.
Yeah, that's such an important insight, just that really, both of these data tell us a similar thing, but are different enough that they're kind of almost telling us different things about the same thing. And so I was just curious for other people on the VLC if they have kind of unique approaches to looking at both acute and chronic data to gain insights on certain subpopulations. Maybe New York and California are leading the way. I wanted to open up and make sure everyone on the call had an opportunity to ask questions. I can sit here and continue to ask a bunch of questions, but this is for you guys to learn from some real experts and leaders in elimination planning and target and indicator development. So I'll shut up.
I have a question for Zakiya. Can you hear me?
Yes.
So I may have missed this, but I was wondering who are the stakeholders within your state that are part of the elimination planning?
So the stakeholders, was a voluntary group, and we kind of reached out. We had an existing group and we reached out to additional stakeholders. So we have people from different parts of the health department here, our STD, HIV, Viral Hepatitis Program, our infectious disease surveillance, immunizations, our substance use and injury and substance use division. And we also have our state agencies, our drug and alcohol agency. We have one person from our Medicaid agency. We also have from, what are they called? Like those larger, we have someone from our hospital association, our federally qualified health center, the Primary Healthcare Association. We have substance use disorder treatment sites, and MAT sites, and we have folks from like our CBOs and our ASOs from our prevention program. I think that's mostly it. We have some providers as well doing Hep C treatment across the state. I think that's it. I've reached out to a bunch of other folks, and it's kind of hard getting some folks in, because I know I reached out like to the United Way and reached out to the AARP and other, and our prison, our state prison, they're involved as well. So it's just a variety of stakeholders from around the state. We have about 60, 70 people, and then we have about maybe 30 or so people across our 5 different work groups.
So are you guys meeting virtually, or how does that work right now?
Yeah, we're meeting virtually. We may change that in the future. I think for the work groups, we'll probably keep those virtually. But I'm very excited for when we can finally meet as a big group. We had a meeting planned like the middle of March of last year. So that got canceled really quickly. But yeah, we're meeting virtually.
Other questions?
I have a question. This is Isabel from NASDAQ again for Zakiya. So what are the conversations like, or what is the process like in terms of target development between prevention and surveillance?
Well, one thing I will say about the targets, what we did mostly, it was mostly us internally working on the targets, and then we asked for feedback from our work groups for developing them. So mostly in prevention, we developed the targets, and then we worked with our surveillance for how we can actually get the information. I know I originally requested birth dose data for like the Hep B target, but then after talking with immunizations, they were able to explain what information they have and what they can pull. And so we were able to edit it. And that's the same thing we were doing as well with our surveillance, infectious disease surveillance group too. So it's pretty much them letting me know what they have and how we can edit it a little.
I'm noticing that there was a question in the chat that I missed earlier, and it was about how both this, increase in funding for prevention surveillance, in particular surveillance, might lead to increased actual follow-up and counting of Hep C cases acutely, and then just as well as with the 2020 case definition, which might be a little sensitive. So in that sense, we might be actually artificially increasing what we're reporting back in a way that might look like we're going further in the direction that we'd hope. And the question was, are there things that you've done to adjust for that, or how should we approach this likely improved reporting as a good thing, but then might make us look bad?
So in the early conversations when we were developing the prevalence estimate in New York State, we knew that we were putting money into building the infrastructure around surveillance, and that there would be a change in that number, that prevalence number, which has a domino effect down the road in terms of our targets and our metrics, in terms of our targets. And so we just had to, realize that is likely going to happen. And we will address it when it does. And we've actually been starting to talk about that as we develop this deduplicated data set known as HEAD.
Great. Yeah, I would say my talking point would be, the arc of elimination is long. And so we're, investments made today will have really positive impacts. And so we're thinking not just about numbers coming out in the next few years, but really numbers coming out leading up to 2030. And so I think it's fine to have that caveat. I don't know that we have a really good, this is the adjustment that you can use to, decrease like what we really think is out there. But I think over the long term, it will start to even out in such that the trends and the changes that we make today from these investments will even out, and we should be able to adequately measure just over that. Maybe it's a little jumbled in that first 5-year period, but the latter 5 to 10 year period, really, I think we should be seeing some pretty accurate data. I see a question in the chat from Danica, and it's for Colleen. For your collaboration with New York City for the estimates and the elimination database, did you utilize data use agreements? And then did they participate in metric development?
Yeah, so, oh boy, data use agreements, right? Yeah, those are definitely, I think we have a ton of data use agreements right now, because one of our other challenges is that surveillance doesn't sit in the same area of the department where prevention is. So we have data use agreements around sharing data back and forth there. So yes, we have data use agreements with the city health department. They have been involved on, I've worked with the New York City Department of Health Hepatitis Program for 20 years now, and we continue to work with them. So we've worked with Angelica Bocor and her team, our surveillance team, worked together on the establishment of the metrics, and obviously they feed data to us. a data set to us to do the development of HEED as well. And I don't know if Lucilla wants to mention anything else about the collaboration, but with the city health department, but we just couldn't do this work without them. We need a statewide prevalence estimate, not one for just upstate and New York City. We needed a statewide prevalence estimate for elimination. Lucilla, did you have anything to add about the work with the city?
Yeah, I guess the only thing to add is, like, underline 100 times the need for data use agreements. These are, they sound simple, but they are complicated to establish. You need the involvement of your legal teams on both sides of the signatures. So they take really long time to establish, and when they are in place, they frame the work, and it is a written understanding of what you're going to be doing with the data and how you're going to share it and with what frequency. We also have applied for to do a match with vital records in our state, and that really takes years, I would say, to be established and in place and ready to go, where from the point in which you have the idea to the point in which you actually get a data file from vital records. So yes, establishing HEED has been incredibly challenging, because again, it sounds simple to combine surveillance data from 2 different reporting jurisdictions, but there's nothing simple about it. Every single time we think we are close to having a full data set, we run into another roadblock that we have to solve and make a decision on. But each day we get closer to have a final data set.
Hi, Nate, this is Fatima. I actually wanted to follow up on a question that Zakiya asked earlier, and I'm kind of interested in hearing a little bit more of it, because it's a little bit of a theme that's kind of playing throughout this, which is there are all these amazing programs that that are happening in New York State and in South Carolina, and of course across jurisdictions. But you've had to narrow down the sources that you're actually going to pull from to measure your performance based on the indicators or the metrics that you selected for your elimination plan. But Zakiya, you asked towards the end of your presentation, how can we use other statewide data sources to demonstrate progress? And I'm wondering if a part of making the determination related to sources also has to do with capacity and like who's going to do this work of measuring performance. So I'm hoping you can just talk about that a little bit more. And I'd be interested to hear from other jurisdictions if they're kind of struggling with how do we measure performance.
Yeah, and I said that's always the really tough part, is that you can measure all sorts of stuff, but it really comes down to what's meaningful and then what's feasible. And so in a lot of cases yes, measuring performance. Yeah. So I think, for the, like core indicators, proxy indicators, things that are national level databases, those are easy enough to pull from. And so those, I think, are really low hanging fruit for including in your strategic planning. I think the real difficulty comes down to whether or not you decide to include programmatic data, and you may not. So for instance, the HHS plan does not include any programmatic data. And so, you can look at the WHO plan to think about some of the testing, treatment, vaccination sort of programmatic measures that, that might be relevant, but I think it really also boils down to what relationships do you have with all the different players in your jurisdiction? Because a lot of time, those data are not within the healthcare department. They might be at SSPs, healthcare systems, Medicaid systems. And so that, as was described with the prior conversations about headaches of data use agreements, like that entails a lot of work. And so really, I think if you're in a less position to have not that many people, it may not make any sense to add programmatic indicators to your strategic plan and just stick with those core indicators as outlined in the national plan, or maybe some of the other statewide data that you may have ready access to. I'd be curious to hear from others on the call if they've had good examples of programmatic data that, or even process data that they would mind sharing, and that think that it would be really useful to improve in their, to include in their strategic plans.
Yeah, one of the things I was thinking of is like, how can we use some of these data sources to, some of these other data sources to, I guess, get a better feel for our main indicators. Like for our mortality data, if we can use maybe like cancer registry data or other data to get a better picture of actually how many people are dying due to hepatitis. And also thinking about how we can use, like we were thinking about using behavioral risk factor survey data and seeing if we can use some of that to get a better idea of how many people are living with hepatitis in the state. So we were just trying to think of things that could maybe make our main indicators better and how we can improve them. But also using programmatic indicators would be great. And we can definitely put that in there, like our testing data and other things due to our grants and things like that. But I think that was, I was thinking of how can we make these indicators better and show a much rounder picture of what's going on in the state.
I think, you know, data sets, I think almost all data sets have limitations to them, right? And I think, Zakiya, you brought up the fact that, you know, race ethnicity data is oftentimes missing. We see high rates of missing data in race ethnicity, some demographic risk factor data. And what we hope to do is augment that surveillance data by matching to other, you know, data sets. And one big data set that we have in the AIDS Institute is what we call our AIDS Institute reporting system, AIRS. And so one of the things that we would like to do is be able to match the surveillance registry, which is everyone in New York State, you know, who's been diagnosed, or almost everyone, and match it with AIRS, who are the AIDS Institute funded providers, including the SEPs, the syringe exchange program. So all of the syringe exchange programs in New York State report client level data through our AIRS system. And so we, you know, we hope to be able to match HEEDS with AIRS, and to be able to augment some of that data, because we have very good race ethnicity data in AIRS. We have very good risk factor data in AIRS. They are required elements, well, demographic data, not so much risk factor data. So I think it's augmenting our surveillance data with these other data sets. But like I said, they all have different limitations, like Medicaid, for example. You don't have test results. You have CPT codes, but you don't have test results. And you don't know whether someone actually was cured, but you know that they initiated treatment. So it's exploring those data sets and understanding their limitations, and taking those into account when you use them.
Larissa, would you want to hop on and share your comment? Oh, mic isn't working. I'll read it. So, Larissa said, in New York, you know, we've added some questions to our BRFSS survey asking about Hep C testing, diagnosis, and treatment. And the sample size was actually large enough for the question about testing, but maybe too small to figure out diagnosis and treatment.
Yeah, we did have a couple of years of data from BRFSS, but we decided to discontinue it just because we really couldn't. It wasn't that useful to us.
Great. So as you can see, you know, indicators and targets, definitely a science, but there's a very heavy artistic component as well in terms of trying to get, just in a sense, feel whether or not you have holistic data that's relevant, representative, valid, and meaningful to measure. And so a lot of the tricky part is that you know, when figuring out what that looks like for you, it's going to look different across all the different jurisdictions. And so really great that there's a virtual learning collaborative for us to be able to share what others have done to get you thinking about it. But ultimately, it's going to rely on sort of what the view looks like from your perspective. And so We're here at CDC to help you. Our friends at NASTAD are here to help you as well. And so we will, be ready to, field any of your questions. But I think the questions for this session, we've run out of time. And so let's see, I think I'm supposed to help close the session. So in the chat, I think my colleague will post a link to a survey that can give you the opportunity to tell us how we're doing just with this session and in general about this format. And then also I'm to note that the October 2021 to July 2022 VL sessions will be changing to start at 3 p.m. Eastern time. And the sessions will be 60 to 90 minutes long, depending on the topic. And that there'll be a link in the chat to all the subsequent planned sessions, as well as recordings of prior sessions. So that if you have any questions, you can email at hepatitis@nastad.org. So with that,
Sorry, Nate, I just wanted to make sure I had a chance to thank you, as well as Zakiya and Colleen for wonderful presentations. Nate, thank you for excellent moderation, a great discussion, and thanks to all of our participants. And we look forward to everyone joining us in October. Again, reminder that our October sessions will start at 3 p.m. and please do complete the survey. That's how we know how to continue to improve on these sessions for all of you. But to all of our participants and particularly our speakers, thank you so much.
Thanks all. Bye now.